Good afternoon, everybody, and sorry we are a bit late. We had some technical issues. Welcome to this webinar, which is the latest in a series of events held by the IHI office to demonstrate the impact of the project that we fund. My name is Oussama Karoum, and I'm Scientific Officer at IHI. Next slide. So in today's webinar, we will focus on 4 IMI projects that have been involved in developing vaccines against Ebola. And for that, I'm delighted to be joined by 5 excellent speakers. And to demonstrate the scale of this cross-sectorial and global project, our 5 speakers are based in 5 different countries located in 3 continents, including Africa, Europe, and North America. But you will hear more about them one by one when I will introduce them before their respective presentations. The slides are not moving. Next slide, please. About this, yeah. So this is the agenda of the day. After this short introduction, you will have a series of 5 very interesting presentations, followed by a Q&A session, when you will have the opportunity to ask questions in writing to the speakers. And then we will conclude with closing remarks, including the promotion of an ongoing call for proposals from a sister funding organization, which is called EDCTP3, which has launched a call for Ebola last month. So stay tuned till the end to get more details about this funding opportunity. Next slide, please. So before we start, just a few housekeeping matters. Firstly, we want this to be an interactive session. So although your microphones will be muted, we do ask you to post any question you may have in the chat at any time during the webinar. The question, of course, will be answered at the end during the Q&A session. Secondly, the webinar is being recorded, and the recording will be made available on the IHI YouTube channel after the webinar has finished. So with no further ado, let's start with the first presentation, which aims at setting the scene and explaining the rationale behind the launch of the IMI EboVac projects. This will be presented by Professor Deborah Watson-Jones. Deborah is a medical doctor and professor of clinical epidemiology at the London School of Hygiene and Tropical Medicine. Deborah is based in Tanzania since many years now, and she is the coordinator of 2 EboVac projects. Deborah, the floor is yours.
Thank you very much, Oussama, and thank you for inviting me to present and to set the scene for these 4 major projects. Next slide, thank you. So first of all, I'm just going to run over Ebola. I think most of the world has heard of Ebola. It's a deadly virus disease which has a very high death rate amongst those infected. We call this the case fatality rate, and in past outbreaks, this has approached 25 to 90% of those infected who will die from the virus. It's an RNA virus with 4 species. The virus habituates Central and West Africa, and since 1976, we've had 35 outbreaks, with about 35,000 people being infected that we know about, and about 15,300 who have died. We do predict that environmental changes and climate changes will lead to increasing frequency of these outbreaks without adequate control measures. Next. The virus is believed to be transmitted from bats, who are thought to be the host of the virus, to other mammal species that live in the bush and forests in this part of the world of Central and West Africa. People have a spillover event and catch the virus when they come into contact with an animal that's been infected. So for example, someone hunting for bushmeat may pick up an animal after it's been killed and handle it and get infected. And they pick up the infection from body fluids such as sweat, blood, urine. They take the virus home with them, unbeknown they're infected at this point. They pass the virus on to household members through their own body fluids and to carers who are looking after them when they become sick. So they excrete the virus in their sweat and their urine and their body fluids. And particularly we get transmission events when the person dies, because at that point they're very, very infectious and people handle the body to clean it and do traditional practices before the burial. So this is really how the virus escapes, and environmental changes, of course, lead people to being exposed to these animal species perhaps more frequently. Survivors suffer from stigma. They may have some ongoing health problems such as aching muscles and tiredness. And we now know that there is also some limited sexual transmission from survivors to their partners. Next. So I think most of us are aware that the most severe outbreak that we know about in history was the 2014 to 2016 outbreak in West Africa. The first case in December 2013 was an unidentified disease in a patient in Guinea. It rapidly spread, eventually affecting Guinea, Sierra Leone, and Liberia. Its case rate was so fast that it was declared a public health emergency in August 2014 by the WHO. Control measures began to kick in, and eventually the outbreak ended, but it was over 2 years later. So in that time, we had over 28,000 cases, and we had over 11,000 deaths, so extremely serious. At that time, there was no vaccine or cure available for this virus. So essentially, it was supportive care and isolation of contacts and of the individual cases. It's critically urgent then at that time to have developed and tested a vaccine that could prevent people from catching Ebola and prevent the spread of the disease. Next slide. So in 2014, in August of 2014, Janssen accelerated its Ebola vaccine program in response to the outbreak. They had a 2-dose heterologous regime. So that means 2 different vaccines within the vaccine regimen, the Ad26-Zebov and the MVN Philo vaccine, which you'll hear more about in the next presentation. This vaccine was very protective in animal studies where animals were exposed to Ebola, highly efficacious, as we say, with a 56-day interval between the first dose and the second dose. And in December 2014, the Innovative Medicines Initiative launched these 2 grants for the EBOVAC-1 and the EBOVAC-2 consortia to basically help the accelerated development of this vaccine, and to EBOVAC-3, a new consortium in June 2018. Next. So there's a great platform of trials here. And just to give you some broad stroke picture of what was done, under EBOVAC-1, the first in human studies were done to look at the first safety and immune responses of the vaccine, and to look at what sort of intervals we might need between the first and the second dose, and to start looking at how long the immune response lasted. These were done in Europe and in Africa. And then EBOVAC-2 looked at phase 2 studies in both Europe and Africa, looking at the safety on selected schedules and the immunogenicity and safety in children, the elderly, and HIV positive populations in Africa, and of the effect on immune responses and on safety of a booster dose in adults. The phase 3 study in Sierra Leone was part of EBOVAC-1. This was a study that was planned to look at the efficacy, the protectiveness of the vaccine against actual Ebola cases. And it was also going to collect some additional data in children and look at a booster in adults. So this was going to be the primary vaccine efficacy or effectiveness study. Next slide, please. We had a number of other studies within these projects. EBOVAC-1 looked also at the RVSV vaccine made by Merck, as well as the Janssen vaccine in the PREVAC study in Sierra Leone. There were booster studies in children and also in HIV positives. And EBOVAC-3, which is ongoing, is looking at safety and immunogenicity in younger infants, 4 to 11 months old, who are very badly impacted by Ebola. They suffer high death rates. So it's very important that we know they're protected. Also looking at frontline workers like health workers in the Democratic Republic of Congo and looking at boosting in these groups. And then long-term follow-up of our participants vaccinated early in Sierra Leone. Next. One of our major issues was to select a study site during the epidemic in Sierra Leone. There were a number of studies going on. We ended up working in Cambia district, northern Sierra Leone. Next, please. So northern Sierra Leone on the border with Guinea. It was a community that was not hosting any other Ebola vaccine studies. And our modeling showed that this area was likely to be one of the areas that would continue to have Ebola for longer than some other areas. So more likely that we would be able to measure vaccine effectiveness. And we had very good stakeholder and community support in that area. Next. So the epidemic actually then took its own turn. So this graph shows you in the light blue line the number of cases that started to come in over time. So by May 2014, the case rate was rising, as you can see. There's like a mountain going up here, very steeply. And then around December, when we got the funding from IMI for the studies, the epidemic was going up and down a lot, still very high. As we started the EBOVAC 1 and 2 projects, you can see the light blue line, it's the yellow arrow there. The light blue line is starting to fall. So the control measures that were being put in began to have a grip on the epidemic: isolation of the cases, isolation of the contacts, good care, etc. Gradually, the epidemic started to come down, and then it came down very quickly. And what has been so wonderful with IMI has been the flexibility for allowing us to change the design of the project. So we were able to continue in Sierra Leone with a study called EBL 3001, but was not the full vaccine efficacy study, and you'll hear about that, and to continue the other studies I've described, despite the fact that the outbreak began to decline. Next slide, please. So partnerships, we had funding approved before our partnerships because of the urgency. So many partnerships were put in place after we got the funding. That's another unique aspect, I think, of the IMI program. Not all our partners were classical research partners. We had support from NGOs such as Goal for logistics. EBOVAC 1 worked with partners in Europe. The industry partner is Johnson, of course, and then we worked with Sierra Leone and countries in East Africa. The EBODAC project had partners that supported that program, including World Vision, another organization, NGO. Next slide, please. And then we had partners for EBOVAC 2 that included West African partners. And in EBOVAC 3, we had partners now also from Belgium and from the Democratic Republic of Congo, as well as Sierra Leone, and a partnership from the Coalition of Epidemic Preparedness Innovations that work on vaccine development for emerging infections. So these are very valuable partners for our program. Next slide. Finally, I just want to thank everybody, all the projects for the work, and all the partners for bringing many of these studies, or most of the studies, to a very successful conclusion, and for helping us finalize the final few projects. Thank you.
Thank you very much, Deborah, for setting the scene, which is really key to understand the starting point and the situation at the beginning of the project to better measure the magnitude of EBOVAC achievements that we will start to hear now with normally Dr. Cynthia Robinson. Cynthia, can you hear me well? We cannot hear you.
Mute me. Can you hear me now?
Cynthia, we hear you well. This is great.
Oh, excellent.
Excellent.
Okay.
So Cynthia is based in the US, working on as senior medical director at Janssen Pharmaceutical. She is the medical leader guiding the clinical developments of Janssen's Ebola vaccine since now 6 years, 2017. And Cynthia was also the industrial project leader of 3 EBOVAC projects. Therefore, there is no other persons more qualified than Cynthia to present the clinical development program of the Janssen's Ebola vaccine. Cynthia, over to you.
Thank you, Osama, for the lovely introduction. I hope I live up to the challenge here. So the challenge we were facing in 2014 in the largest outbreak of Ebola in history was, how do we go from a vaccination site in rural Cambia, Sierra Leone, to 6 short years later to EMA approval of our vaccine? And I can tell you that 6 years of development time is actually quite rapid. Normally, it would take a decade or even a dozen years to achieve approval of a vaccine. Next slide. Next slide. Can you advance the slide? There we go. You've seen this slide before, so I won't belabor it, but we were developing a novel 2-dose heterologous vaccine against Ebola. Heterologous means that the 2 components are different from each other. The first vaccine, Ad26-ZBOF, contains the coding region for the glycoprotein that coats the outside of the Ebola virus, followed approximately 2 months later by MDA-BN phyllo, which also contains the coding information for the same glycoprotein code. What's important to realize about this vaccine regimen is that both vaccines are non-replicating in humans. This means that they can't multiply and they can't cause disease. Next slide, please. Next slide, yeah, okay. IMI supported a very robust clinical development program, which consisted of 23 clinical studies in the US, Europe, and Africa. And participants included elderly individuals down to infants and including pregnant women. And the sum total of this experience resulted in over 260,000 vaccinations across the world. And importantly, the EBOVAC studies figured prominently in the successful licensure of this vaccine by IMI in July of 2020. Next slide, please. What you see on this slide visually shows the importance of the IMI-funded studies. Everything in red are IMI-supported studies, and that black vertical line indicates when we received IMI approval. So everything to the left of that line was pivotal in the support of the initial submission for licensure. Everything to the right of that line indicates ongoing support of IMI for the future of this vaccine. Next slide, please. You've seen this slide before, but I'm going to put a slightly different spin on it. So our pathway to licensure was a bit unique. As shown on the graph, J&J made the decision in August of 2014 to accelerate the development of this vaccine. By the end of the year, we were in our first clinical trial, phase 1 clinical trial. But at the same time, in the green arrow at the bottom, we kicked off commercial scale manufacturing, which means we manufactured upwards of 3 million doses of a vaccine that we didn't know whether it would work yet. That was followed by first phase 1, then phase 2, then phase 3 clinical studies. But as you can see, the conduct of those clinical studies occurred as the epidemic in West Africa was tailing off. So the challenge to us was, how were we going to infer clinical benefit in the absence of an ongoing outbreak? Next slide. Fortunately, both the FDA and EMA have alternative pathways to licensure spelled out. And this is called immunobridging strategy to infer clinical benefit, or it's otherwise known as the quote-unquote animal rule. To successfully use the animal rule for licensure requires an animal model that closely resembles the human disease. And then you can see at the bottom here a bunch of red circles. Those are animals that did not receive the vaccine but were exposed to Ebola. And you can see that they were 100%, it was 100% lethal. None of those animals survived. At the top, you can see a bunch of red circles. Those are animals that received the vaccine and then were exposed to Ebola, and all of those animals survived. You then take a measurement of protective antibodies in both sets of animals, and you plot it on a curve that describes the relationship between the magnitude of the protective antibody response against the probability of surviving. And when you do that, you calculate a mean survival probability, and it's 95 or 97% confidence interval. And in agreement with the regulatory agencies, if that lower bound of the 95% confidence interval was above 20%, then you can infer that the vaccine provides a clinical benefit. Now, this is, there are a couple of important things to know about the animal model. The first is that it is more aggressive than the human disease. This means that any survival probability calculated for people is likely to be an underestimation of the true clinical benefit, and that to determine the true clinical benefit requires a field study, which is a requirement when the animal rule pathway to licensure is used. I belabor this point because I believe that this novel pathway to licensure will come into play for other significant pathogens that have a sporadic outbreak. Next slide. So when we gathered all of our human data and put it on the curve, the protective antibody concentrations, we have a mean predicted survival probability of 57.3%. Now, this is not the same thing as vaccine effectiveness because of the stringency of the animal model. And you will see that the lower bound of the 95% confidence interval is 41.2%, which is well above the agreed upon 20% threshold by the regulatory agencies. So this is the basis for licensure. Next slide. Obviously, assessment of safety is an important piece of any clinical development plan. And this was assessed by means of a diary card and investigator inquiry to collect local and overall body symptoms. And the vaccine has been shown to be safe and well tolerated in all populations studied to date. Next slide. So I had mentioned earlier that IMI's support of this vaccine did not end with the registration of the vaccine. It continues to the present day. And I would like to share with you one of those enduring impacts, and that is the persistence of a binding antibody response. The graph shows the results in HIV-positive adults, and that you can see they received on the left-hand side the primary vaccination with a rise in the protective antibodies that then declines by 1 year period of time. After 4.5 years, they received a booster dose of Ad26-ZBOB, and you can see the remarkable rapid increase in protective antibody response that peaks at 3 weeks after that booster dose. And this is important because although circulating antibodies may come down after the primary vaccination, clearly that primary vaccination was sufficient to educate the memory cells so that when the individual sees the glycoprotein a second time, they mount a rapid and robust memory response. Next slide, please. But IMI's impact extended well beyond the initial registration. We then applied for WHO pre-qualification of the vaccine, and it was granted in April of 2021. This is a requirement or a prerequisite in order to allow UNICEF and Gavi to provide funding for the vaccine in developing countries. We also had facilitated reviews of the program with several African nations, and this has led to approval now in 5 African countries. Next slide, with more on the way. So I'd like to summarize the impact that IMI has had on the development. Thank you. I think you've seen that the private-public partnership has been critical for the successful registration of this vaccine by providing financial support, but more importantly, pulling together talented partners who have each unique contributions to this development. Next. But the support that has been provided extends now into the future with the ability to answer additional questions about how this vaccine should be best utilized in the field. Next slide. And this development program supported by IMI has led to a lasting legacy of these commitments. The safety data collected here benefits other vaccines like IMI-supported vaccines like the COVID vaccine. We have ongoing publications coming from our partners that educate the community how best to use this vaccine. During the course of development, we have trained personnel, and whenever you have talented personnel, they attract new projects. And last but not least, the flexibility to explore alternative pathways to licensure during accelerated development was very important to this program. And the extent and depth of community engagement was also pivotal in order to achieve this success. And next slide, I would like to thank the organizers for allowing me to present the impact that IMI has had on the development of this vaccine. Thank you.
Thank you. Thank you very much, Cynthia. Thank you for also highlighting the role and the contribution of the IMI EboVac project to the Ebola vaccines development contribution, which, as you said, was critical for getting these vaccines ready to be used. We've seen a few questions coming in the chat. Just a reminder that you can use the chat throughout the webinar. These questions, of course, will be answered during the Q&A session. So now we will talk about, next slide, please. Now we will talk about the capacity building and strengthening. And for that, I would like to welcome our next speaker, Professor Baila Lee, who is a physician and he's the head of the Community Health Department at the College of Medicine and Allied Health Sciences at the University of Sierra Leone. And is also the principal investigator for the Janssen-sponsored Ebola prevention vaccine. Professor Lee, the floor is yours.
Thank you very much for allowing me to present. Now, the Ebola trial has, phase 1 trial has several sites, one in Oxford, then we have in Africa, Kenya, Tanzania, and Uganda. These African countries were not affected by the Ebola pandemic, by Ebola outbreak. Then we chose them because they had vaccine trial experience, and that will allow pass off the critical early phases of this trial. Then the capacity building was done through conduct of studies, and then we raised awareness of the outbreak in West Africa. Next slide, please. However, there are challenges for those countries that were affected by the Ebola virus disease. For example, there was a lack of infrastructure. Some sites had no suitable premises to host the trial or laboratories. There was lack of power and electricity and even water. Some countries had little or no experience with vaccine trial research. Research management skills needed to be strengthened, and so that because they were lacking. Few staff had experience in leading vaccine trials. On the human resource side, there was a shortage of health workers and scientists in these countries. Health workers were dying because they had Ebola during the outbreak. In Sierra Leone, there was also a balance of priorities at the Ministry of Health, but the Ministry of Health thought that we are taking their clinicians away for our research, and they didn't have enough clinicians. So this was a problem that and we didn't have enough clinicians in the country and very little researchers. So we still try to get some of the clinicians from the ministry and so on to be able to carry out our research. Next slide, please. Further challenges we had were issues we had were, for example, equipment and maintenance. There was a technical support gap because there are hardly any skilled biomedical technicians. Even for maintaining and servicing equipment, there was challenges. We didn't have enough engineers, so we had to bring people, specialists from Ghana and Kenya, to help us out. The supply chain challenge and shipments was increasingly difficult in many of these low-income countries, and because the sites were in remote places in most of these countries. Then the COVID epidemic also made us close field workers in the field, and then the supply shortages also existed. Next, please. The pictures you here are examples of remote locations. For example, in Burundi, in the Democratic Republic of Congo, the site was very much remote and hardly reachable. You could reach the place after about 3.5 hours trip, or by boat, lasting for 10 days trip from Kinshasa. The next slide, please. Capacity building was also promoted by the IMI investment. This was very important for us. We had to construct buildings. For example, in Gambia, we had to construct a vaccine depot system, and we converted a building, a room in the hospital into an emergency room. And then we had to set up clinics in renovated buildings that were rented in Gambia and Mambolo in Sierra Leone, or in local hospitals. For example, in Burundi, they used a reference hospital as a clinic for that. All these sites had problems with power supply. So we had to get generators, and fair supply chain was established to make sure that we have electricity whenever, as long as it was needed. And of course, hardly did they have any internet services. So these services were installed and were moving. In order to identify the participants that are coming for the vaccines, and so we had to improve the participation, the identification of this. For example, we had to use iris scanning to identify the participants, the right participants for the vaccine they came for. Next slide, please. We had also to expand laboratory capacities in all these sites. For example, in Gambia, Sierra Leone, we had to build a research laboratory where clinical laboratory facilities were provided, and also facilities for serology laboratory and PCR laboratory. In fact, recently we had a liquid nitrogen plant installed. Next slide. Training was very, very crucial and very, very well taken. We had to make sure that the clinical staff were trained in good clinical practice and protocol procedures. Emergency medicine training and pediatric training also was offered to this clinical staff. And then in one center, for example, Center Moraes in Burkina Faso, they had a training of methodology of vaccine trials. The pharmacy and the cold chain staff were also trained in blinding and the allocation of concealment for those people who are taking part in the trial, and sustaining the cold chain. We were also trained in that aspect, and vaccine monitoring and accessibility training also took place for them. The laboratory staff were made compliant with good clinical laboratory practice, and technical skills training, especially in new assays like PCR, Luminex, and ELISA, also took place for them. Then they were also trained in sample transport and management and storage, because some of the samples were sent outside of the country for analysis and so on. Next slide, please. Then further training took place in the data group. They are trained in data management and basic statistical software. The qualitative research training also took place, for example, about study design, interview techniques and analysis. And the research administration and logistics staff were also trained in stock management and software, and they were also trained in administration, procurement, and finance systems. All this training helps the site for future research, example for the Ebola 3 project. Next slide, please. We had a good relationship with the ethics and regulatory authorities in Sierra Leone. We had extensive communication with these authorities, and they helped us expedite review processes for Ebola-related studies during the outbreaks. We are engaged also with the African Vaccine Regulatory Forum. This was a platform for conducting joint reviews of clinical trial applications, and the AVAREC, they also assisted with regulatory and ethics review capacity in these countries. We even had face-to-face meetings with them with AVAREC in Tanzania for the phase 1 trials, and there was also one in Sierra Leone for the phase 3 trial. The part of the Ebola 3 group has also investigated the experience of the ethics regulatory bodies in Sierra Leone, Guinea, and the DRC during the past Ebola outbreaks to improve preparedness for the next outbreak. Next slide, please. In conclusion, the IMI investment in Ebola and Ebovac projects has greatly assisted in capacity strengthening for future trials, as well as allowing the Ebovac studies and trials to be conducted at a very high standard and in contributing to vaccine transmission to prevent and control Ebola in the future. This has also contributed to the licensure process. The Ebovac and Ebovac projects have also built confidence in conducting vaccine trials and other research studies in these countries. And with that experience, many Ebovac and Ebovac staff have gone on to do masters and other postgraduate trainings. For example, in Sierra Leone, we have had over 10 participants go on to do masters training abroad. The laboratory and data management strengthening will be invaluable for research in infectious disease and future outbreaks of emerging infections. Next slide, please. Next slide, please. I thank you very much, the organizers, for allowing me to make this presentation. And I thank the sponsors and funders of all the trials and also the funders. Thank you very much.
Thank you very much for your presentation, Professor Lee, as it gives us also another very important perspective of the project achievements related to capacity building, which will contribute to increase preparedness for future outbreaks. For the next presentation you will see is also very interesting, as it provides an overview of the supporting activities and the development of innovative tools to support the Ebovac clinical trials that Cynthia has mentioned in her presentation. For this, I would like to welcome Annick Williams, who is program leader at Janssen Pharmaceutical. She's also the industrial project leader of the Ebodac project, which was designed specifically to support the clinical activities of the Ebovac project. Annick, we are very eager to hear more about the supporting tools developed by the IMI Ebodac project. Over to you.
Thank you. So I will speak about Ebodac, which stands for Ebola Vaccine Deployment, Acceptance and Compliance. The program, as Osama said, was set up to ensure compliance with the 2-dose vaccine regimen in West Africa. And in the program, we focused on community engagement, identification tools, and mobile technology, phone technology, to remind participants of an upcoming visit. In the community engagement pillar, we linked up with a team of social scientists. Next page, please. And social scientists, there were actually the eyes and the ears for the trial. So they would listen to what individuals were saying about the study through clinic exit interviews, but also was going to the local market and listening to what was being said. A key lesson from the qualitative research of the team is that context matters. Historical, political, social, and economic factors that influence trust in vaccines. It is really key to understand that communities are not homogeneous, and an in-depth understanding of community power dynamics is really important to diversify your communications. Power, fairness, and trust were themes that emerged from the research in Sierra Leone. For example, as a result of conversations that the team was having in the communities about the perception of fairness, the clinical team decided to use a public lottery system to choose the order in which people were invited to the clinic as a potential volunteer. The team also identified the rumor of blood stealing. So there was a concern going around that your blood was taken in the trial and that it was being sold to other countries. The community liaison team then created spaces for dialogue and to address this concern and make sure that it was explained correctly to the potential volunteers. Now, research often focuses on why people refuse vaccination. In this case, the social sciences team looked at motivations for volunteering for the study, and they have found that in Sierra Leone, the motivations were sacrifice and citizenship in time of crisis, having access to healthcare, curiosity about the trial, and hope for the outbreak to end. Now, while the social sciences team has shown value of understanding of the local context and taking this into account from the start of the trial design, it might be difficult sometimes to translate these findings into clinical trials because, for instance, of the very strict protocols and standards you have to adhere to. Next slide, please. Memories of Ebola have generated new ways for communities to prepare for future outbreaks. And as an example, during the new outbreak of Ebola in Guinea in 2021, Gambians developed community-level monitoring systems, like the informal border checks that they did. Still, today, the social sciences research continues to explore those social dynamics to develop better response strategies. For instance, they're currently studying contact patterns in Gambia town. Next slide, please. Another example of localized communication is the flip chart that was used in the informed consent process. That flip chart had illustrations drawn by a local artist on the one side and text to read for the health worker on the other side. It was used to explain the trial and the different steps to the volunteers. For instance, with the picture that you see here, we explained that participation is voluntary and that you can decide to leave the trial at any point. Next. As Dr. Lee already mentioned, we used biometric identification at each clinic visit to verify person identity and also to verify that it was the right window for vaccination with the second dose. We used the iris scanning and the fingerprinting in Sierra Leone because, like in many African countries, people don't have an identity card. Now, the biometric kit that we used in the first studies, the picture that you see on the left, was quite bulky, and sometimes you were in a small doctor's office. Also, as you can see, you had to put your face against the camera, which is not ideal if you're doing a study with an infectious disease like Ebola. So over time, the solution has evolved into a mobile tablet, the picture that you see on the right, with a handheld iris scanning device so that you don't have to touch the participant anymore. We also studied the feasibility of doing iris scanning in children and have shown that it can be used for children as of the age of 3. If they're younger, it's not feasible because they don't hold still. Next slide, please. Also, the IMI funding that we received in Ebola allowed for capacity building to prepare for deployment of a licensed vaccine. And here you see an example of the capacity building. One of the tools that was developed was the Mobile Training and Support Service. We called it MOTS. That was used to train community health workers on Ebola vaccination campaigns, just using their basic phones. So what the platform does is it is sending training modules, training content as pre-recorded audio messages in local language to the phone. As a community health worker, you only need to pick up the phone and listen to the training module, and you can use your keypad to respond to quiz questions that we had put into the training. A system like MODS was repurposed in 2019 for a mental health training of 50,000 community health workers in Rwanda. Next slide, please. In 2017, EBODAC also organized a symposium in Dakar, bringing together experts from across Africa and beyond. So we shared the learnings in the EBOVAC trials with other programs, and the output of all of those conversations was bundled into a training resource, a guidebook, which is available as open access tool on the Vaccine Conference website. Next. And during the conference and also in our research, we identified different factors that need to be considered when deploying an approved vaccine, like a possible deployment in an emergency setting, the fear Ebola evokes, also being unfamiliar with targeting high-risk individuals of all ages rather than children vaccination campaigns. And so we bundled all those challenges, we did more research, and we developed a gap analysis tool that ministries of health, local governments can use to assess their own readiness to deploy a licensed Ebola vaccine. So that it contains checklists and references to solutions if you identify any gaps. And we have validated the tool in DRC, Uganda, and Senegal. Next slide, please. And to end, here is an example of how we moved from Ebola to COVID. The biometric solution that I explained evolved even more into Vaccinate, which is now available as an open source tool with real-time data reporting and also visit reminders for the participants. It has been used by Ministry of Health in Rwanda in a large-scale Ebola vaccination program called Imirinzi. And what's also special about the Imirinzi program and the use of Vaccinate is that they have an exceptionally high compliance number. Even during COVID-19, they have 94% of the 200,000 participants did return on time for their second dose. And then we have moved on to COVID. The tool is also being used in the Solidarity vaccine trial of WHO in different countries. Next. And I would like to thank IMI and all the different consortium partners for making this possible. Thank you.
Thank you very much, Annick, for your presentation, which really shows the importance of community engagement, but also communication and the developments, as you highlighted, of innovative approaches and tools to ensure the successful development of a vaccine or potential deployment of a vaccine during a vaccine campaign. So now I would like to present our final speaker, Professor Rodolphe Thibault, who is a professor of public health and biostatistics at the University of Bordeaux in France, and is also the coordinator of the EBOVAC2 project on behalf of INSERM. Rodolphe will have the difficult task to talk about the very interesting non-clinical research side of the EBOVAC project. And Rodolphe will also conclude before we move on to the Q&A session. Over to you, Rodolphe.
Thank you very much for this kind introduction. It's a real pleasure to be here with you today, remembering the start of this project in 2015. So here, what I'd like to underline is the research side of those projects and what we've done, so beyond the accelerated vaccine development, to better understand the effect of the vaccine, to be ready to adapt the developments if needed, and also to learn beyond the developed vaccine. So I'm going to talk very briefly with a high-level presentation of research projects on non-human primate studies, on immunological studies, and modeling studies. Next slide, please. So here is about the non-human primate study. So the idea was to continue the work in non-human primate experimentations in the United States and in France, And you have heard already a very nice presentation from Cynthia Robinson, where actually all of these data have been used to perform the immunobridging studies, helping them to use the animal pathway for the FDA approval. And so those data has been very useful, and the idea was potentially to use also the information to confirm the effect of the vaccine with more data. And this work has been done in this context. Next slide, please. So then there was the all of the immunological studies. So I'm going to show you that on only one slide, although the work that has been done here is huge. So the idea was to basically disentangle the effect of this vaccine strategy and look at what is the impact of this vaccine strategy on the immune system. One of the first actors is the innate response, and especially the natural killer cell, the NK cells. And this work has been coordinated by Martin Goodyear at the London School of Hygiene and Tropical Medicine, and has led to several publications, and with very nice and interesting results about the change of the phenotypes of the NK cells following the vaccination. Next slide, please. Then there is also the very important effect of this vaccine on the B cells, which are the cells that will be ultimately responsible of the antibody production, the antibody against the Ebola virus. And a large part of this work has been done by the Oxford group, the Oxford Vaccine Group, led by Professor Andy Pollard. And again, here, a huge bulk of work has been done to understand the dynamics of the response to the vaccine. And for instance, one of the first application was to look very precisely to the response, to the B cell response, to define the next sampling in the next trials and studies that we have settled in this consortia. Next slide, please. Another part of the immune system, which is also playing a big role in the vaccine response, is the cellular response with the CD4 and the CD8 T cells, which is, in one hand, will help the production of the antibodies, as you can see in the middle of the scheme, and in the other hand, with some cellular response that will act directly against the virus. A large part of this work has been done by the INSERM team, led by Yves Lévy, and especially also Dr. Christine Lacabarat at the Vaccine Research Institute. And they have shown how this part of the immune response has been committed by the vaccine. Next slide, please. Then there are the modeling studies. So there are several types of works that have been done. The first type of work done through INSERM and INRIA, and especially the research team that I'm leading, it was the idea here was to use mathematical model to first capture what we measured in terms of vaccine response, to be able to predict at the individual level, and also to predict in the future what would be the duration of the vaccine response. We started this work with the phase 1 data, and interestingly, we initially found that with the 6 months follow-up, we predicted that, for instance, the half-life of the cell producing the antibodies could be at least 5 years. So it was our very initial results that were very encouraging about the durability of the response. And then came the phase 2 data that helps to confirm the good prediction of the model, which is represented here on the figures, with one part which is being the forecast of the models, and that fits very well the data that we obtain in the phase 2 data. And the other results is that we updated the half-life of these cells that are producing the antibodies from 5 years to 15 years. So again, a very encouraging results in terms of the duration of the response provided by this vaccine strategy. Next slide, please. The other part of the modeling studies, led mainly by the team at the London School of Hygiene and Tropical Medicine. And so it was about the modeling of what's going on between hosts, between the individuals, and especially about the Ebola transmission between hosts. The two types of questions, among others, that have been answered was to assess the impact of different vaccination programs on the control of outbreaks of Ebola virus disease. So, for instance, the type of strategy that have been compared are the ring vaccination versus the mass vaccination. Another type of work, which was very important also for future development, was to look at how to maximize the power and optimize the designs to try to evaluate the vaccine according to new outbreaks. And so this was first done through modeling studies to look at what would be the best design in that situation, so in preparation of future outbreaks. Next slide, please. So in terms of general conclusion, I think that this Ebola program with those 4 consortia is a very important example of an accelerated vaccine development program, which was really crucial to get the vaccine ready to be used to protect the population against this Ebola virus disease. And I'd like to underline on behalf of my colleagues the full involvement of the institution, and also, you know, up to the people in the field. A lot of people have been involved in all of this research and development, and it's really the role of all of them that helps for this development. And also the capacity building, as Dr. Leth has demonstrated in his presentation, was also a very important side with now, you know, labs that are still working and that could be useful really beyond this Ebola vaccine development. Also, this innovation side, and including the research that I've shown you very quickly, which is very important and has also served for instance, the COVID pandemics. And finally, you should notice that it was very multidisciplinary consortia with very different expertise that has been bring together to make this possible. Next slide, please. So as I said, it's a lot of people with those 4 consortia, and you can see here all the institutions with also the African institutions that have been involved from the beginning in the constitution of these programs. But we should again underline the role of everybody involved in this on the field, in the labs, and it was really the commitment of many people to reach this success. And I'd like also to thank the IMI for the support to make this possible. Thank you very much.
Thank you very much, Rodolphe. So the mathematical modeling, as well as the more fundamental research and the immunological work that have been done in the EBOVAC projects are always very difficult to explain and to simplify, and you did it very clearly, so thank you. And on this very tangible concluding remarks from Rodolphe, I would like to open the Q&A session. We received questions that I will now read to the speakers to get their insights. So first question, and I'm reading, so I'm quoting, so this is certainly huge. Do you have an assessment of cost benefit, basically return on investment on this must be huge. How does one assess this? I think maybe Cynthia, if you heard this question, it's more maybe for you.
Well, thank you for the question. And indeed, this was a huge effort. You can see that it involves the, the partnership of academic institutions, a public company, IMI, and other NGOs. And I think it was in part because of the urgency of the situation deteriorating on the ground in West Africa. I'm not an economist, so I can't. I know that there are folks who understand how to calculate value and benefit, but I think that it. How do you put a value on someone's life, and how do you put a value on stopping an epidemic and stopping future epidemics? So I think the value, not only for the development of this vaccine, but everything that we've learned during the course of this development that we can apply in the future. Over.
Thank you. Thank you very much, Cynthia. That's very clear. Another question. And so we saw that the EBOVAC program is composed of 4 different projects. This is something which is addressed to all of you. Could you explain how these 4 projects, which served the same goal, actually, have ensured a close collaboration between them?
Osama, perhaps I can start, and then others. So you're talking about the 4 projects, EBOVAC 1, 2, 3, and 4. Well, the first, and then obviously there's EBODAC. Sorry, I didn't mean EBOVAC 4. I think the first issue is that from the very beginning, there were 3 that started almost simultaneously with some of the same partners, and EBODAC strongly supported EBOVAC. So there were regular joint meetings for those 2 partners. We had a system in place for what we call project management office meetings, where partners came together to discuss various events. And there were regular project meetings with partners from both projects, if you like, plus EBODAC attending them. So I would say the communication was extremely strong because both EBOVAC 1 and 2 were setting up in parallel, and some of the same investigators from both studies largely for the different phases of the studies. The whole governance structure also allowed for very close communication with the same level of high-level governance for the studies. And EBODAC basically joined us in many of the meetings. We had, as you know, annual meetings, but we had more frequent meetings in which all the projects were represented at those, and there were partners who were only working on one who would attend the other. So it was set up at the beginning in parallel, and that really helped. For EBOVAC 3, which has started later, again, we have many of the same partners working on that, because in a sense, it's a follow-on from the unanswered areas that need to bring this vaccine forward to licensure. We have the same industry partner in all the projects. And again, the sort of same mechanism, if you like, for the meetings and arrangements has happened. Now, EBOVAC 1 has now ended. So, of course, as has EBOVAC 2. So we don't bring those on board so much with EBOVAC 3, but we still have many of the same investigator and country partner organizations. And they attend the regular meetings that we have. So I would say that compared to many consortia one's been involved in, this has been particularly tight, I think, in terms of communication, and helped tremendously, I think, by the industry partner who knew what questions still needed to be addressed, and then worked through the consortia to get those particular studies underway.
Thank you, Deborah. Anyone wants to add anything on this?
Well, it's just to say that, first of all, so it's clear that we had to be in a very intense communication from the beginning to really perform this accelerated development. That's the first point. But the second point is that, as you may see today, there are some clear outcomes about how good was the communication and the collaboration. The first thing is this seminar where actually we merge together things that have been done in several of the consortia, and the research part or the modeling part is an example. And the other thing I like to underline is also this communication, so went beyond, with connection beyond the EBOVAC and EBODAC consortia. And PREVAC is a very good example where there was a big connection then between the consortia. And so that's, I think, a very good success in terms of communication between people and institutions.
And I would just add two things. The first is, and nobody ever talks about this because it's touchy-feely, but the partners, the leaders of these work packages genuinely like working with each other. And that makes a huge difference when you're working inside a consortium. And the other success story has to be that we defined at the beginning what the roles and responsibilities were, so that everyone knew what their deliverables were, and we weren't stepping on each other's toes trying to accomplish a singular goal. We all knew what our roles and responsibilities were, and that helped. Over.
Thank you all. Next question. You said that the vaccine is already approved in the European Union and in several African countries. Is it approved by the FDA in the United States? And if not, could you explain why and if this is planned?
We elected to not submit to the FDA, in part because it was not an urgency for the national strategic stockpile to have this vaccine at the time. We don't, at this point, we don't intend to submit to the FDA, but rather we're focusing our efforts to get as many African countries approved as possible, because that's where the need is. Over.
Thank you, Cynthia. Next question. Can you please clarify how long the protection from the vaccine is likely to last? It wasn't clear what the actual evidence is in the end.
That's for me. So first of all, so sorry, I had to do very quickly and as simple as possible, but then you missed probably some information. First of all, it was the modeling of the dynamics of the antibodies. So you should keep in mind that it's not directly the protection that is modeled over time. So it's really the dynamic of the antibodies. And according to this dynamic of the antibodies, we were able to estimate the potential duration of the cells that are producing the antibodies. And so I was talking about this half-life of the cells, the survival of the cells that are producing the antibodies. And what I mentioned is the fact that initially, with the very short follow-up of 6 months from the phase 1 trials, we were evaluating already a lower bound of this half-life of 5 years. And then with the longer duration available from the phase 2 studies, we were able to estimate this at 15 years, so which is the lower bound of the half-life of the cells that are producing the antibodies.
Okay, thank you, Rodolphe. Next question, which is more of a comment. So would be useful to have a lessons learned regarding what went well and what did not. There have to be lessons learned regarding what were the challenges, because everything can't be smooth at the time, all the time. Sorry. Who wants to take this?
Just address one lessons learned component that's in EBOVAC 3. So I think this is a very important comment, actually. And I guess you're imagining lessons learned from working within these large consortia. But there were also lessons to be learned about trying to do research during an outbreak. And we have, as part of EBOVAC 3, been asked to document the experience and lessons for regulators and ethics in dealing with research and vaccine trials, and specifically, I think, during the Ebola outbreak and what recommendations have come out of that. That is one of the deliverables in EBOVAC 3, in involved workshops and interviews, etc., with those committees. At the moment, we don't have a component within EBOVAC 3 for other lessons learned, but I think the point, if I understand the question correctly, is perhaps we should look at the consortia in terms of what worked very well and what might be useful for IMI in the future in setting up these consortia that might be useful for future funding and large projects like this.
Yes, indeed, Deborah. Thank you for your answer, but also thank you for these comments. Next question. One needs 2 doses of the vaccine to get full protection. During an outbreak, this will not be ideal as one needs more than 2 months to get full protection. Are there plans to continue to explore this 2-dose vaccine regimen to reduce the immediacy of immune response?
Well, that sounds like it's a question for me. The question is a pertinent one that because we use the animal model to determine, to infer clinical benefit, we have the issue where the animal model is more aggressive than the human disease. And so we know from the outset that the data generated using that model underestimates the true efficacy. And in addition, the threshold or the correlate of protection for Ebola and vaccines has not been determined. So it may very well be that the circulating antibody response after the first dose may actually be protective, but we just don't know that because we don't have the models to be able to determine whether or not that is the case. SAGE, which is the Scientific Advisory Group of Experts, has evaluated the landscape of the various Ebola vaccines and has recommended that during an outbreak, the single-dose vaccine produced by Merck should be deployed in a ring vaccination strategy, and that the 2-dose heterologous vaccine has a more appropriate place in prophylactic vaccination, i.e. in peacetime, but also to be deployed in areas that are surrounding the hot zone to prevent the spread into those areas. So there is room in the community at large for 2 different vaccines that target slightly different aspects of the Ebola virus life cycle. And as Debbie has pointed out, Ebola has become endemic in certain countries, with outbreaks becoming more and more frequent. And thus, a role for preventative vaccination is becoming increasingly important as time goes on. Over.
Thank you. Thank you very much, Cynthia. Next question. What were, I think it's more also, sorry for you, Cynthia, but also I think for Annick, what were some of your findings related to trust in the vaccines also, and how many people have been vaccinated since the vaccine came onto the market?
Yeah, for that second question, I'm counting on others. I don't have the number, but for trust, yeah, I think what was also said during the presentation is that it was very important to understand the local perceptions and experiences. Like in Sierra Leone, there is a history of war, so there was some mistrust in what local or national authorities might say. So I think it was important to understand their fears, their concerns, so that we could react to that. Like there were some rumors going around that the vaccine can be used by governments to control population, etc. So we could give them the right information. We could explain how a vaccine worked, but also understand, for instance, what would be a reason for them to contribute to vaccine development, to participate in a trial. It might be different in different countries. Like in this case, it was very clear that one would do that because you're part of a community, because you want the outbreak to end, less for you as an individual. So it was important to understand all those different perceptions, past experience, history, to make sure that we could react and give them the right information. Like there was also concern about just taking blood, huge amounts of blood. So we used a kind of tube to show them like this is the amount. It's not like I used a spoon, a tablespoon, to show them the amount of blood compared to maybe ideas that I had in mind. So just listening, social sciences team was helping us with that, and then communicating and addressing their concerns. Yeah, about the numbers, I'm not sure. Maybe Cynthia or Debbie, do you know the number of people vaccinated so far?
That's difficult to estimate because, for example, Umarinzi was conducted after we had a European approval, and it was conducted under an emergency license or something, exceptional circumstances or something like that in Rwanda. And a similar scenario in DRC, where we are vaccinating up to 40,000 healthcare workers in the Mbadaka region, again, under a emergency license. So that's a bit difficult to answer because we're in the process of trying to get approvals from various African countries, and then they have, since we have WHO pre-qualification and a SAGE recommendation for how the vaccine should be used, now it's time for those governments to place a request into Gavi and to UNICEF to get the vaccine so they can prophylactically vaccinate. So it's a complicated series of events, so it's difficult to answer that question precisely. Over.
Thank you both.
I just wanted to add.
Yeah.
I just wanted to add to the fears and trust. I mean, like in our sites, people were complaining that a lot of the health workers we brought were from the south, and there's not so they thought that had political reasons, and that we were giving them the vaccine to kill them. But then, fortunately, the heads of the chiefdoms, the paramount chiefs, and so also took the vaccine, and they were also there that they have not died, and we, the doctors, are also there. If it was to kill anybody, we would not have given health workers. So the social science group was very useful and in trying to engage the community and explain these things to them with the help of the paramount chiefs. Of course, I cannot talk about numbers also here. Thank you.
Thank you, Professor Lee. Cynthia, you mentioned WHO pre-qualification. There is a question about this. On one of the slides mentioned WHO pre-qualification of the vaccine. Could you further explain what that really means in practice?
It is a prerequisite for allowing the participation of both UNICEF and Gavi to fund or support the requests coming from developing countries to purchase the vaccine. So if you don't have WHO pre-qualification, then the pathway towards that financial support is closed. So you must have WHO pre-qualification before you can get the participation of those funding agencies. Over.
Thank you. Some of you made the link between the actual project and other infectious diseases such as COVID, for instance. And you mentioned that the data collected also benefited other vaccines developments like COVID. Could you further explain this point and how clinical data collected for an Ebola vaccine can benefit other vaccines?
Well, I think it was more that the tools used to collect safety information could be adapted from Ebola to COVID, as well as the Ebola vaccine development resulted in a large safety database that could inform the development of another vaccine using the same type of vaccine. So it's, when you're starting a development of a novel vaccine, you don't have any safety data that you can rely on. But if you're using a similar type of backbone in your vaccine, then you can rely on the already established safety database. So I think that's the reason. So both the tools and the existence of a safety database helped the development of the COVID vaccine. I hope this answers your question. Over.
Thank you, Cynthia. Now there is another general question, and I will partially respond to it as well. With the scientific results obtained so far on Ebovac 1, 2, 3, and Ebodac, will you say there is scope to conduct more investigations on Ebola virus? If so, what will be the areas of interest for further research on the virus? Just before I give you the floor to respond, our next point will be the promotion of an ongoing call for proposals that have been launched by EDCTP3 on Ebola. So that's partially also answered the questions, but if anyone wants to add anything. Debbie?
Yeah, thank you. I mean, I think that Cynthia may have more comments on this, but I think one of the big issues that's going to happen is the gap between these outbreaks, really, and whether people who have been vaccinated for, say, an earlier outbreak or prevention of cases within an area where there was an outbreak, will still be protected. So it's duration, really, of protection that's going to be key, I think. And that's, in terms of measuring efficacy, is challenging alone, but measuring, duration of protective efficacy is also going to be very challenging. But that's, for me, I think, one unknown question that we have been asked quite a lot about by ministry people. If they get their health workers vaccinated, would they need repeated boosting, etc.? And if so, when?
Okay, thank you very much. So unfortunately, we have other questions, but time-wise, we have to stop the questions now. We could see really during this webinar how the Ebovac projects and a perfect example, actually, as said by Rodolphe, of accelerated vaccine development program, which was really crucial here for getting a very tangible and impactful achievements, namely a vaccine ready to be used to protect populations against Ebola. Now moving on to the next slide. As promised during the introduction, I would like to promote an ongoing call for proposals on Ebola research, and also to respond to one of the questions during the Q&A that was launched last month by our sister funding organization called EDCTP3. The call is about research to rapidly evaluate intervention on Ebola outbreak in sub-Saharan Africa. You can also see here on the slide an overview of the scope of this call. But of course, you will have access to more detailed information by following the link on the slide, which will lead you to the call topic. And for your information also, this presentation with the links will be available on our website. One important point here, of course, in this slide is the deadline for submitting your application to this call is the 29th of June. So next slide, please. We are already preparing next event, new events, next events to show impacts to other areas such as cancer or other vaccines impact events. So that will be held towards the end of the year. So please visit our website and follow us on Twitter and LinkedIn to be kept informed about our project achievements and all future webinars. Next slide, please. And before we close this webinar, a warm thanks to the speakers, not only for their time today and for their presentation, but also for their great commitment and hard work on this very challenging IMI project. And thank you all very much for joining us and for your active participation during this webinar. Wishing you all a very good afternoon. Thank you. Bye-bye.
Thank you.
Bye.
Bye. Bye.
Thank you all.